some of the, let's say, progresses and without going in detail and without mentioning numbers, but rather principles where we see the evolution towards. And the theme and the topic is towards individualization and personalization in the treatment strategy in GI cancer. Since we are not in Barcelona, I'm in Leuven right now. Just one picture, one slide. For those who don't know, you see the hospital and the health science campus. Leuven is just east of Brussels, a small university city with 100,000 people. On top of that, 60,000 students. The university is founded in 1425, and you see on the right side some of the Gothic city hall and some of the buildings and pubs in the city. The university is also #1 in Europe in the Reuters ranking of innovation. And for those who are interested, we have the largest beer brewery in the world. More than 25% of the world production of beer is controlled here. I don't have any conflicts with the beer, but Stella, but also Corona, Beck, Budweiser, that's all controlled. Not that everything is made here, but all controlled out of Leuven, with headquarters being here. That's not the topic of today, but in these virtual meetings, I always like to introduce a little bit from where we speak. In cancer management, I often say that there are 4 Ps: prevention, personalization, the prediction of what we do, and the participation and involvement of the patients. Today, the team will be more around the personalization. As I mentioned, this be at other occasions we've been talking on prevention, screening, or other topics, or with DiCE we have had masterclasses on molecular markers, and it's more on the P of predictive, and we have had masterclasses on the P of participation. Just one slide on the cancer incidence, because that's still striking. In 2020, there were around 19 million new cases of cancer worldwide. Almost 10 million people died from cancer. And you can see the distribution, lung cancer being #1 when we look at mortality. But then several of the digestive cancers, unfortunately, are high ranked in the mortality. More than 9% of the cancer deaths worldwide are colorectal, 8% liver, between 7 and 8% stomach cancer. If you look at some of the numbers, and on the right side, you can see for genders, for males and females, slightly different rankings, of course, with breast cancer and prostate cancer playing an important role in female and male patients, obviously, in this setting. But that just gives the scope. Where do we see the personalization? I will not talk a lot on screening, but in screening also for colorectal, but also for some other cancers. Pancreatic cancer, we are more and more implementing, and we had some sessions at ESMO GI this year on screening and hereditary predisposition for pancreatic cancer. We know that 5 to 10% of the pancreatic cancers have a hereditary predisposition, which is most frequently BRCA mutations, but also some other mutations in pancreatic cancer. And there we go more and more with the surveillance program. Well, in colorectal cancer, it's also important. Everybody knows this, the FAP syndrome, the Lynch syndrome, but there are some other less frequent, so more rare germline alterations, mutations that predispose to colorectal cancer. And in screening programs in the population, we look into the average risk screening with FOBT, but we look also more and more in towards germline screening and integrating that to look for high-risk screening populations in this situation. So that's an important topic in the individualization of screening. Most of my talk, I will talk on the management, on the treatment, and first part is on colorectal cancer, and I will show a couple of slides on colorectal, on stomach cancer, on esophageal cancer, and on pancreatic cancer with more principles and more directions where we are making progress towards. If you look in colorectal cancer, as a clinician, if I see a patient with colorectal cancer, with metastatic colorectal cancer, I want to know the situation, the location of the metastasis. Unfortunately, the minority has resectable metastasis. If they're resectable, then we will remove them, we will resect them. But the majority, as on the right side, have unresectable metastasis. And then we want to give a chemotherapy with a biological. And then the art is to select the best chemotherapy. Because if you look on the progress that is being made, 15, 20 years ago, there was only one drug, 5-FU. That was the only drug. You can see it in red on the left top in the cytotoxic agents. Today, we have a list of 6, 7 different chemotherapeutic agents, cytotoxic agents, as we call it, and a list of more than 10 different targeted biological agents, either less specific, such as angiogenesis inhibitors, such as bevacizumab, either more specific, such as cetuximab, panitumab, the BRAF inhibitors, either immunotherapy checkpoint inhibitors, and most of these target a specific subgroup of patients with metastatic colorectal cancer, and therefore the molecular unraveling is crucial and is important. And with this combination of these different agents and targeted agents, we want to come up with the best strategy for the patients, and we want to determine if we see a new patient with upfront unresectable disease, go back, and that's going back to my algorithm that I've shown of resectable and unresectable disease. I'm speaking most often on unresectable disease. In this situation, we want to know, do we want to treat the patients aggressively or not aggressively? And therefore, we can come up with, in fact, if we see a new patient, with 7 different treatment options, being a less aggressive treatment, just capecitabine or 5-FU in combination with the angiogenesis inhibitor, or a doublet, so 2 cytotoxics, go back, and if you go back to the previous slide, on 2 cytotoxics, can be FOLFOX, CAPOX, FOLFIRI, in combination with a targeted agent with bevacizumab, or depending on the molecular analysis with an EGFR antibody. Or we can treat a patient with a triplet with 5-FU, oxaliplatin, irinotecan. We call that then FOLFOXIRI, in combination with a targeted agent from the right column of this big column of 20 different agents, bevacizumab, or an EGFR antibody. So with that, we have already 5 different treatment options in the first line. Or we can treat a patient if the tumor is what we call MSI high, microsatellite unstable. That means that there are a lot of alterations, a lot of mutations in the tumor. Then we can treat these tumors with a checkpoint inhibitor, with an immunotherapy. And today, pembrolizumab is approved in this situation. That's a 6th line of this table, pembrolizumab, as you can see. Or in the future, maybe for the BRAF mutant patients, we may treat these patients with a targeted treatment against BRAF mutants. So then on top of that, we look into is a tumor localized on the left side in the column or on the right side? We look at the molecular characteristics, and then we come up with a preferred regimen. So with this situation, we determine, we individualize the treatment options. So that's where a lot of studies are being presented without overviewing all the different studies. You can unravel that a little bit, even a little bit more in this situation with looking at the molecular subgroups. And if you look at molecular characteristics, without again going into detail, that will lead us too far. But if I see a patient with colorectal cancer, I want to have in 2021 information on the different characteristics that are mentioned here on the slide. I want to know, has a tumor a RAS mutation or no RAS mutation, and then we call it RAS wild type. If there is a RAS mutation, I want to have details on which type of RAS mutation. I want to know if the tumor is MSI or MSS. I want to know whether the tumor has a BRAF mutation or no BRAF mutation, whether the tumor is HER2 positive or HER2 negative, and whether the tumor has an NTRK alteration or no NTRK alteration. These are all alterations in the molecular subtypes that are druggable. So therefore, we have a specific treatment strategy going back to the previous treatment algorithms that we know. And then maybe in the future, we want to look at others. And that's shown in the slide, in the diagram on the right side. You see some alterations where we, polypody, for instance, where we may look at in the future, they are rare, but to come up with an optimal treatment strategy. And that's how we define, how we determine what we do in patients with colorectal cancer. And that's just illustrated here for the patients with an MSI high tumor. And we know that some of the patients with in the MSI high group, that there are patients with Lynch syndrome, but that there are also patients with so-called sporadic cancers. 4 to 5% of patients with colorectal cancer have an MSI high tumor. If that's the case, we will treat them with pembrolizumab instead of chemotherapy with a targeted agent. And if you look at the progression-free survival, the progression-free survival of patients treated with immunotherapy with pembrolizumab is clearly better than with chemotherapy. That's what's shown on this slide, and therefore this was approved. You can look at the same numbers in a different way. You can look at the response rates, and on the left bottom of the slide, at the waterfall plots, as we call them. In green, the green lines, the different small lines represent an individual patient. And you can see with in green that more patients with immunotherapy treated with pembrolizumab, the green bars are going below the horizontal line of 0, meaning that there are more patients with tumor regression compared to on the right side with chemotherapy, where you see less patients. So in other words, in an MSI high tumor, more patients benefit from an immunotherapy compared to what the chemotherapy. And in the future, we may go to different treatment options also with immunotherapy without going into detail into that. So looking into that, that brings and that summarizes in colorectal cancer and the treatment algorithms that's based on the updates of the ESMO guidelines. We see more of, you can come up with a treatment guideline in this situation for patients. We look what we want to achieve. We look at the molecular characteristics. We look at the sidedness of the tumor. And with that, we come up with a treatment algorithm, and you see that taking into account these different dimensions, the goal of the treatment, what do we want to achieve, the molecular characteristics, the presentation of the patient, and the location of the primary tumor, we can come up with a preferred treatment option without going for this audience into details. And we can do that for first-line treatment. We can do that for second line, that are patients who receive the first line treatment but who fail later on. You can see that in this situation, the column of the molecular alterations is expanding based on the knowledge that I've shown you, the wheel that I've shown you earlier on the different molecular subgroups. And in the future, it will go even further in this setting, really unraveling the molecular characteristics of patients with colorectal cancer in this situation. That will individualize the treatment options. And that's what we were discussing and what we are discussing at ASCO, at ESMO GI in this setting. And with that, we can improve the outcome. And yesterday, some of the Belgian newspapers reported falsely that there was no progress being made in colorectal cancer and that there is a lot of cost being in the management of colorectal cancer. Well, this is the curve of patients with metastatic colorectal cancer over the last 20 years, with the median survival going up from 6 months to 30 months today, so times 5, as long today compared to 20, 30 years ago in colorectal cancer. Unfortunately, we don't cure them. Unfortunately, that costs a lot. That's correct. But that's the impact of individualization. 2 slides on esophageal cancer. Without going in detail, that's the classic algorithm that we have developed within ESMO, the European Society of Medical Oncology. If you look on the right side, metastatic disease, on the left side, locally advanced disease. In metastatic disease, the treatment options are limited. We give chemotherapy with modest impact in chemotherapy. What have we seen in the last 6 months? And I've highlighted that in red on the slide. So the additional studies in the last 6 months have shown that in metastatic disease, immunotherapy, most of them are with immunotherapy. You can see pembrolizumab, nivolumab, or nivolumab plus ipilimumab, or teslizumab in metastatic disease, in squamous cell cancer, or as well in adenocarcinoma, that today, in metastatic disease, these different immunotherapy, maybe not for all patients, but for patients with a biomarker, the PDL-CPS score, if that's present, and that's present in a positive score in 50% of the patients, that we then can clearly improve considerably the outcome. We don't cure the patients, but we can improve the outcome in metastatic patients. So that's an example of individualizing, personalizing the treatment for patients with metastatic disease. That's adding in first line to chemotherapy, a fluoropyrimidine plus a platinum, a FOLFOX regimen, for instance, a checkpoint inhibitor in immunotherapy that will improve the outcome of patients. And also in locally advanced disease, so patients who can be cured potentially, that after the operation, as you can see in red also on the left side, after the operation, so these patients receive preoperative chemo and radiotherapy, then operation, and then after the operation, nivolumab, that after the operation with nivolumab, we can improve the outcome also in patients. So that's the example in esophageal cancer. 2 slides on stomach cancer. That's the ESMO Asian algorithm of gastric cancer. And what you can see there is that in first line, we have, for metastatic patients, we have chemotherapy. I will not go too much in detail in this. But if you look on the next slide, on this slide here, in red again, I added what has changed over the last 6 months. And this is the same schematic representation of the ESMO, JESMO, Japanese guidelines and European guidelines, added in red, where you can see that, for instance, in first line, we add nivolumab plus chemotherapy in patients with a PDL, so that's a score on the tumor, and that is positive in a select group of patients, 50% of the patients. If that PDL receptor is positive, we will improve the outcome of patients with chemo plus nivolumab in this situation. In second line, we have drugs targeting HER2 positive patients. 15% of patients are HER2 positive. In the past, we treated these patients with trastuzumab. Today, and that should be in red, we treat these patients also with, in first line with trastuzumab, pembrolizumab, and in second line with trastuzumab deruxtecan, because both options improve the outcome for patients. So also here, the individualization with new agents, either with immunotherapy, pembrolizumab or nivolumab, either with an antibody drug conjugate, as we call it, trastuzumab deruxtecan, it improves the outcome also in this situation. And almost finally, in liver cancer, this was the ESMO guideline, quite recent, with some updates even in 2020, early 2020, where we had for the patient, the third group is the patients with more advanced liver cancer, hepatocellular carcinoma, sorafenib, levantinib were the standard options. Today, We have also a combination of a checkpoint inhibitor, immunotherapy, atezolizumab plus bevacizumab. And you can see that not for all patients, but for some of the subgroup of patients, there will be a benefit of treating these patients with immunotherapy plus an angiogenesis inhibitor. So the algorithms are expanding, the treatment options are expanding, the algorithm is becoming more complex in this setting, also with some progresses over the last 6 months of, for instance, this combination with immunotherapy plus an angiogenesis inhibitor in advanced liver cancer. And finally, pancreatic cancer, 2 or 3 slides on this. This is a difficult to treat disease. The good news is that we are unraveling the molecular characteristics behind pancreatic cancer. And you can see some of the druggable alterations that we have. I will not name them all, but in pancreatic cancer, science is progressing. The translation of science into clinical practice, that still needs to a little bit further work. But if you look in pancreatic cancer, there is step-by-step, although very modest, but there is some progress. What we see is that there are some targetable mutations. BRCA1 and BRCA2, PALB2, they represent 5 to 8% of the patients in this situation. MSI represents only 1 to 2% of the patients. And then you can see some of the others, NTRK, NRG, representing all small subgroups of patients. But step by step, I believe that we're coming there. And that's what we see today in pancreatic cancer, that if you look starting from 25 years ago, there was only GEM5FU, gemcitabine, and then if you look on the timeline, nothing really happened. Erlotinib gemcitabine was approved in some regions, but had no impact. And then it's only after 2015 that we see small steps. FOLFIRINOX, gemcitabine, Naliri in this setting. And then you see that for the subgroups, the individualization, pembrolizumab, olaparib, larotrectinib for some patients is entering into the arena with modest hopes for progress in this situation, but at least also with the message that individualization, personalization in metastatic pancreatic cancer, if we start further to unravel some of the molecular characteristics behind pancreatic cancer, I'm convinced that within the next 10 years, we will have, at least for some patients, hope for progress in this situation. So that's a little bit a snapshot of fast walk through more principles with the message that individualization, personalization, looking at clinical characteristics, but also looking at molecular characteristics and unraveling the tumor and investing in innovation, in research is important in order to do step-by-step small progresses for all our patients. And that's the different topics, talks were around many of these different aspects that I just summarized with the helicopter view. Thank you for your attention.